Good day, class, and thank you for attending this lecture. For this lecture class, we will tackle the third lesson of your finals, which is your Module 9, Transplantation Immunology. So this PowerPoint were presented or prepared by your previous Immunosero instructor, Ma'am Kapatayan, Ms. Katigan, Fundal, and Mr. Villapanya. So these are the authors of your PowerPoint. Please take note, class, that whenever you would copy this recording, please do not copy paste any picture from the PowerPoint itself and try not to upload them in any website. So let's start your Module 9 Transplantation Immunology. Now, whenever we would talk about transplantation, class, the thing you need to remember about transplantation is that this would refer to the process of transferring an organ, a tissue, or a cell from one place to another. From the word trans, meaning to transport, and to plant or to place. You're going to transplant, class, or you're going to transfer an organ or tissue or cell from one place to another. Now, take note, class, that an organ transplant is a surgical procedure in which a failing organ is replaced by a functioning one. Take note of this, class. You're only going to perform an organ transplant when the organ in target is already failing or dying. An example of this, class, let's say you have uh, a case of diabetes mellitus. Now, in a case of diabetes mellitus, class, you have a problem with your pancreas. Now, the organ is transplanted either in two ways, class. The first way is that it could be transplanted in a way known as your orthotopic. When you say orthotopic, this is implanted in the same anatomic location in the recipient as it was in the donor and requires the removal of the disease organ. So let me emphasize on this orthotopic, class. Same anatomic location in the recipient as it was in the donor. So if it's located in your heart, if you're going to receive a heart transplant, automatically you're also gonna put it in the same at an anatomic location. It requires the removal of the disease organ. So this is more applicable, class, on heart transplant, liver transplant, pancreatic transplant, and so on. Now, another type of transplantation is your so-called heterotopic, implanted in another location, class. An example of this is when we talk about yung mga tinatawag nating mga burn victims. Ngayon, pag ikaw nasunog ka, class, naging burn victim ka, one of the most common procedure that is done to heal your skin is what we call your skin grafts. Your skin graft, you get a graft of skin. Let's say, kumuha ka ng balat sa legs mo or sa thigh. You would place it in the burned part. So that's your heterotropic. An example of that is your skin graft. So you're going to implant it in another location. This organ is kept in place. So take note of the difference. Orthotopic, same anatomic location in recipient and donor. Heterotropic, implanted in another location. So those are the key words that you need to take note of. Now, other things you need to remember, class, is that in kidney transplant, this is the treatment of choice for almost all patients with end-stage renal disease. Take note of this. If you know a patient with end-stage renal disease, when you say end-stage renal disease, class, these are the patients that are undergoing dialysis as well. The considerable mode of treatment is kidney transplant. For pancreatic transplantation, represents the most reliable way to achieve euglycemia. When you say euglycemia, normal normal glucose levels or normal response to glucose in patients with uncontrolled diabetes. So again, I will ask you all later if it really is okay if you have diabetes mellitus class, is it ideal to perform pancreatic transplant? Pancreatic transplant. Uh, if it is ideal to perform pancreatic transplant if you have diabetes mellitus. Then liver transplantation has become the standard care for many patients with end-stage liver failure or liver cancer. So pag kidney transplant, end-stage renal disease, those undergoing dialysis, pancreatic transplant to achieve euglycemia, and liver transplant, end-stage liver failure or liver cancer. Now, there is a network class in the United States. This is not applicable in the Philippines, but we just follow the guidelines of this organization. In other countries, such as in the US, there is what we call the UNOS organization, or the United Network for Organ Sharing. So this is the network of hospitals that coordinate on how transplantation should be followed. So in the Philippines, class UNOS concept is the guidelines we follow. But due to many geopolitical and involvement of monetary compensation, many transplant organ has involvement of money. So if you already heard of the news, di ba, yung mga pag gusto mong bumili ng iPhone 14 Pro Max, benta mo yung isang kidney mo. Ganun yung mga usual na naririnig mo, or you would hear stories like that, and you will find people, class, who would actually sell organs. They would actually sell their organs, class, for money. Uso yan dito sa Pilipinas, class. Let's say gusto mong bumili ng isang side ng kidney niya. Some people are willing to pay 100k to 200k. But again, with that kind of money, you are already reducing, class. You are reducing your lifespan if you sell your organ. Sipin mo yung kalahati ng buhay mo, you'll just sell it for 100 to 100k. Now, take note, class, that in the Philippines, the only allowable in the Philippines, class, the only allowable transplanted organ is the kidney. Hindi ka pwedeng mag-transplant dito ng liver, ng pancreas. Only the kidney is the only organ allowed to be transplanted. That is why, class, let's say need mong magkaroon ng liver transplant. Kailangan mo pa pumunta ng Singapore, kailangan mo pumunta ng Hong Kong, kailangan mo pa pumunta ng ibang bansa. You have to go to other countries to have other organ transplant. So let me emphasize on that, ha. Kidney, class, is the only allowable transplanted organ, or the only allowable organ to be transplanted in the Philippines. But if you want a transplant of liver, pancreas, or your lungs, you have to go to other countries to do that. Now, we have an hospital here in the National Capital Region, specifically in Quezon City, known as the National Kidney and Transplant Institute, also known as your NKTI, class. Now, NKTI is the first hospital in the Philippines accredited to perform kidney transplant. Also, the only hospital who trained transplant surgeon. Now, let's continue. Now, transplantation, class, is a potentially life-saving treatment for end-stage organ failure, cancer, autoimmune disease, immune deficiency, and a variety of disorders. As I mentioned earlier, class, ang transplantation, you would only do this. You would only do this in cases, class, wherein there would be end-stage organ failure. Meaning, class, kailangan talagang palitan yung organ. Kung may cancer ka, may autoimmune disease ka, may immune deficiencies ka. That is when you would perform transplantation. Now, in transplantation, class, there is a specific type of system known as your human leukocyte antigen system. Please take note, class, that this is the largest immunologic barrier to successful allogenic organ transplantation. It would consist of cell surface proteins which play a central role in immune recognition and initiation of immune responses. So remember that. Siya yung pinakamalaking immunologic barrier responsible for successful allogenic organ transplant. Now, another thing you need to take note of here is the so-called major histocompatibility complex, or your MHC. This is a gene, a cluster of genes found on the short arm of chromosome 6 at band 21. Now, how would you procure organs, class? So, you would procure organs, let's say, if yung mga nagda-drive dyan, those who have driver's license, there's always an option in your driver's license pag magre-renew ka or mag-apply ka that are you willing to donate your organ if you die, blah, 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 ganun. So, there are two ways you would actually acquire. The first one would be via deceased donors class. Now, how would this occur? Yung deceased donors class, this is the one that is most commonly done. This is the most transplants. And they would acquire this from deceased donors. Formerly, death was determined by cessation of both cardiac and respiratory function. Now, there are two types of death kasi na nangyayari sa hospital class. Meron tayong tinatawag na brain dead and meron tayong cardiac dead. Now, you could possibly donate. Pwede kang mag-donate in either situation. But before that would happen, class, the doctor needs to confirm that the patient is actually brain dead. Now, take note of this. Typically, brain dead class is defined as the irreversible cessation of brain function. From the word irreversible class, the brain, pag in-scan mo yan sa MRI, the brain would show no brain waves. Basically, class, patay na talaga siya. Cessation of brain function, affecting specifically the brainstem. Now, the presence of medical conditions that mimic brain death, such as drug overdose, side effects, hypothermia, hypoglycemia, induced coma, and chronic vegetative state should be excluded. That is why kaya ako nga sinasabi sa inyo that the doctor needs to confirm, class, that the patient is generally or technically brain dead because there are some conditions such as yung drug overdose, medication side effect, hypothermia, hypoglycemia that could mimic this, kayang gayahin. So baka akala mo patay na yung patient, brain dead yung patient, yung pala nakakomatose lang. So you need to confirm this. Now, how would you diagnose this class? As doctors or doctors would do it, there are four essential steps. Number one is the establishment of proximate cause of neurological insult. So they need to identify ano ba yung cause ng damage sa ano niya, central nervous system niya. Is it trauma? Is it irreversible trauma? Is it due to drug overdose? And so on. Then they're going to perform certain clinical tests to determine if it's a coma, absence of brain reflexes, or baka paralyzed lang, or if the patient is suffering from apnea. Then magpa-perform sila ng electroencephalography or your EEG. Magkaiba class ang ECG sa EEG ha. Ang EEG is for the brain, the ECG is for the heart. Electroencephalography would be done along with cerebral angiography or nuclear scans. Then another thing you need to take note is appropriate documentation to determine brain death in pediatric patients. Excuse me. Now, once the diagnosis of brain death has been performed, you need to perform or initiate the process of donor evaluation and organ donation. So, magte-test ka na ng HLA typing, magte-test ka din ng ABO typing. Now, another type of this death due to deceased donors is yung after cardiac death. So, kapag cardiac death naman, class, this is considered donation by a non-heart beating donors. O yung tinatawag nating NHBDs. Now, these NHBDs, class, are technically non-beating. Wala nang pulso. There is no pulse, there is no heart activity. Now, this was first initiated or proposed, class, at an international workshop and is now mostly widely adopted for organ procurement. Now, ang basis nila in the United States is that the patient should suffer a devastating injury with no meaningful chance of recovery, but does not meet the criteria for brain death. An example of this class, let's say nagkaroon ka ng gunshot. Nagkaroon ka ng multiple gunshot wounds and hindi ka na talaga masisave ng doctor or you will not be able to recover from it. So they would get consent for donation, and if it's approved class, the donor's life support is removed. So that's one way you would acquire it. With a cardiac death class, warm ischemic injury to organs can occur during the period between circulatory cessation and rapid core cooling through perfusion of preservative solution. Ang problem kasi class sa cardiac death, just to explain this last paragraph, the problem with cardiac death class is that there could be a possible organ damage. Organ damage. Why? Remember class, kapag namatay ka na, your temperature, your body temp would tend to go down. And remember, most of your cells, most of your organs need a body temp of 35 to 37 to function properly. Now, if the temperature goes down, the that could affect the organ. So what they would do is that they would perform a rapid core cooling. When you say rapid core cooling class, this minimizes this minimizes organ damage. This minimizes organ damage cooling it by cooling the body at a temperature that would slow cell death. So, 'di ba kapag malamig, they would tend to have a slower cell death class. So they would add certain preservative solution. So I hope that was clear. The first type of organ procurement, deceased donors, either via brain death or cardiac death. Now another type of donation, another type. This is rarely done nowadays, and it's usually done among relatives class or family members. Is the so-called living donors. Now, the thing you need to remember about living donors is that there is an ethical code here. The ethical code here is from the Latin primum non nocere, meaning first to no harm. And in that basis class, yan yung ginamit nilang ethical and legal basis is that whenever you would perform living donor or living donation, there are three guiding principles that you need to take note of based on this first do no harm or primo non nocere. It is that number one is that there has to be the beneficence to the recipient. So the recipient class should have maximum benefit. The second one is non-maleficence to the donor, meaning no damage or at the most minimal damage class to the one who donated. And the last one is the donor's right to autonomy. When you say autonomy class, the donor has the right to allow or to deny. Meaning class with consent. Hindi pwede yung may kukuha ka na lang, may kikidnapin kang bata, kukunin mo yung organ. That's a very big no-no. You have to get consent class. Kaya nga may mga kwento, I don't know if you're aware of this. There are stories class that there are some children daw or there are some people that are being kidnapped. This is done daw by certain black market or trade na they would kidnap people, they would get their organs alive and they would sell it. So nangyayari daw yung organ selling na yan sa ibang bansa. Now, in order to achieve optimal outcome class, transplant professionals should focus on maximizing the benefit. Remember this, ito yung sinasabi ko. Maximizing the benefit for the recipient and minimizing the damage to the donor. Now, the Uniform Anatomical Gift Act, adopted by all states in the U.S., provides the legal framework for competent adult living donors. This one, class. A shorter waiting time generally implies a healthier recipient, one whose body has not been ravaged by prolonged end stage organ failure. Then the use of living donors may significantly shorten the waiting time for recipients. Kasi nga, class, alangan naman mag-aantay ka pa or you have to wait pa for people to die. By having living donors, you can shorten the waiting time. And in living donors, class, transplants are planned better, allowing for better preoperative preparation of the recipient. Now, the major disadvantage here is there is a risk to the living donor, class. There are cases, class, wherein the donor could actually die from having their organ taken. Medically, there is no possible benefit to the donor, class, only the potential for harm. That is why you need to minimize the damage to the donor. So for every procedure, class, like this, for nephrectomy, the estimated mortality risk is less than 0.05%. For partial hepatectomy, when you say nephrectomy, class, we're talking about the kidney here. Tatanggalin yung kidney dun sa donor. And hepatectomy is liver. Kasi in liver transplant, you could actually get a small part or a part of your liver and you could donate that. And it on its own, it could regenerate. Then the risk of surgical and medical complications would also depend on the procedure being performed. Long-term complications may be associated with a partial loss of organ function after donation. The guiding principle should be minimization of risks to the donor, and all potential risks must be carefully explained to the potential donor and written and informed consent must be obtained. So, in-explain ko naman na to in a shortened manner, class, that when we talk about living donors, you have to maximize the benefit to the recipient, minimize the damage to the donor, and there has to be consent all the time. Now, this is in on the table here, sa right side. Take note of the year the different organs were allowed. So, kidney, 1954, liver, 1963, lungs, 1963, pancreas, 1966, heart, 1967, small, 1967, heart and lung, 1981, then multivisceral, 1989. Then there are corresponding surgeons that would be. No need to memorize the location, class. Just the organ, the year, the surgeon, and this may come out in your exam. Let's go now to the so-called major histocompatibility antigens or your HLA antigens. So as I mentioned earlier, these are the ones that are required, the immunological barrier class. Now they would include two types or two classes, MHC class 1, MHC class 2. Now, or your HLA class 1, class 2. Class 1 class would include HLA-A, B, and C, while your class 2 would include HLA-DR, DQ, and DP proteins. Now, these are encoded by a set of closely linked genes on the short arm of chromosome 6 in the MHC region. HLA genes are inherited as haplotypes from parental chromosome. The offspring would receive one maternal and one paternal HLA haplotype. So based on this Mendelian inheritance class, there is a 25% chance that any two siblings would inherit the same two haplotypes. A 50% chance of being HLA haploidentical, share one of two HLA haplotype, and a 25% chance of being HLA non-identical. So let's now HLA genes class are linked and inherited in Mendelian fashion as haplotypes. One paternal A or B and one maternal C or D. Haplotype is passed to each offspring class. Four different combinations of haplotype are possible in offspring. Elucidation of haplotype sharing between siblings is an important assessment in the search for a transplant donor. So ito, tingnan nyo to, class. So you have your A1, B8, A2, B4. This is for the father, and this is for the mother. So there are four different combinations that would occur. The offspring could acquire A1 and A3, Kasi di ba haplotype siya? It could also acquire B8 or B14. So that's one combination. A possible combination would also be A1. Then you could get the A24 from the mother. B8 and B17. That's the second one. The third one is pwedeng A2 and A3, B44 and B14, and A2, A24, B44, B17. So, ang technique dito para mas madali yung ano, let's say may ganyang tanong sa quiz nyo. You just have to pair them up, class. Pair them up from left to left. When I say left to left, yung left ng mother, ay, yung left ng either mother or father. Sige, let's follow na lang yung nasa diagram. Yung nasa left ng father at yung left ng mother. The second combination, class, is that you would do a father-mother ulit. But this time, left to right. The third combination, so bakit left to right? Kasi dito, A1, this is found on the left side. Then, the second combination, A24, nasa right side siya. So, A1, A24, left side yung nasa B8, kinuha yung nasa right side dito. Then, the third combination would be, this time, right naman ng father, and you would get it from the left side of the mother. So, A2, ito yung nasa right, A3, yan yung nasa left. B44, B14. And the last combination would be both, you would get it right to right. So, paano right to right yun? So, A2, A24, B44, B17. So, tandaan nyo lang yan. Pag may tanong kayo sa quiz class wherein I'm going to show you a picture. Yan. Tapos, may mga ganitong genes na A9. What would be the four possible combination? So, you would use this guide. Tandaan nyo lang yan. Left, 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 right, right, left, right, right. So, try to review this again. Excuse me. Okay, let's continue. Now, the three classes of HLA class. So, we have your HLA class 1, class 2, and class 3. Ang pinaka-importante dito, class, the one that is usually encountered is yung class 1 and class 2. So, please take note, class, that the structure of class 1 HLA molecules would consist of an alpha chain, a highly polymorphic glycoprotein encoded within the MHC on chromosome 6. Now, the alpha chain would non-covalently associate with beta-2 microglobulin, a non-polymorphic glycoprotein encoded by a non-HLA gene on chromosome 15. The loci is HLA B, A, B, and C. Distribution, this is found, class, mostly in nucleated cells. Function is to present endogenous antigen to cytotoxic T lymphocyte. Then class 2 naman, class, are composed of alpha chains and beta chains. So if your class 1 is only alpha chains, class 2 class is alpha and beta chains. We have your loci HLA DN, DO, DP, DQ, and DR. Found in most B cells, macrophages, and other APCs, activated T cells as well. Function is to present endogenous antigen to helper T cells. So si class 1 nyo, class, nagpe-present siya to cytotoxic T cell. Si class 2 nyo naman, helper T cells. While your class 3 class would bear no clear relationship to class 1 and class 2, aside from their genetic linkage. Class 3 molecules are involved in immunologic phenomenon because they represent components of the complement pathway. So, importante lang sa class in the complement pathway. Gene products such as C2, C4A, C4B, and PF complement components are incomplete, but the structures are defined by genes lying between or very near the HLA-B and HLA-DR loci. So please memorize this table, class. This may come out in both your quiz and exam. Now let's go to the role of MHC complex and HLA antigen. So the presence of HLA class was first recognized when multiple transfused patients experienced transfusion reactions despite proper cross-matching. So yung HLA class was considered very important kasi when a patient received multiple blood transfusions, there was a reaction or a hemolytic transfusion reaction. And it was discovered later on that these reactions were caused by leukocyte antibodies rather than antibodies directed against erythrocytic antigen. Di ba naalala nyo sa cross-matching class? Especially sa major cross-match. Ang tinitest mo sa major cross-match is the PSTR, patient serum donor RBC. When you say patient serum, we're talking about the patient's antibody. And here we have the donor red cell, RBC, or the antigen. Now, normally, class, sa cross-matching, ang dinedetect mo dyan is the antibodies directed against the antigen. So, yung antibodies dito, this is the one that refers to the patient's serum. So, yung antibodies sa patient serum would attack the donor red blood cell. Ganon sa cross-matching. Pero dito sa HLA, they were able to identify leukocyte antibodies. And these leukocyte antibodies class would attack erythrocyte antigens. So take note of that. So instead of coming from the serum class of the patient, they found that leukocyte antibodies would attack the donor RBC or the donor antigens. The same antibodies were subsequently discovered in the sera of multiparous women. Pag sinabi mong multiparous women class, madami ng anak, multiple children, more than 3, 4, ganon kadami. The MHC gene products have an important role in clinical immunology. Example class, transplants are rejected if performed against MHC barriers. Thus, immunosuppressive therapy is required. Now, these antigens are primarily important and are second only to ABO antigens in influencing the genetic basis of survival or rejection of transplanted organs. So again, class, pag magta-transplant ka ng organ, it is always important to always consider the first one is their ABO compatibility. The second basis class would be the HLA testing. Now, the class 1 and class 2 molecules can also bind to self-antigens produced in the normal process of cellular protein degradation. However, these are not recognized by the T cell receptor, producing a so-called tolerance. Transplant patients with most immune responses are generated not from bacterial antigens, viral antigens, or sub-antigens, but alloepitopes derived from the transplanted tissue to circulating T lymphocytes. So take note of this class. Ang immune response nyo daw, your most immune responses are generated. When you say immune response, it activates antibodies, it activates your T cells, it activates your B cells. Now, this would occur, class, not because of bacterial antigen, not because of viruses, not because of self-antigens, but from alloepitopes, class, from the transplanted tissues. So, may mga, kunwari ito yung, ba to? Kunwari this is your liver, class. Sorry sa drawing. Kunwari ito yung liver nyo. Kunwari lang, this is your liver. In the surface of your liver, class, there would be certain epitopes that could be considered foreign, class. Iisipin ngayon ng katawan mo, These are alloepitopes or foreign epitopes. And from their class, these foreign epitopes from the transplanted organ will cause an immune response, causing, and this is activated or caused by circulating T cell. So makikita ng circulating T cells yung mga foreign epitopes na yan. And it would cause that immune response. So do take note of that. Now let's go to the applications of your HLA. So the most important HLA antigens class are your HLA-A and HLA-B. Now the best possible match whenever you would perform HLA typing is a 6 out of 6, while the worst possible match is 0 out of 6. Now in kidney allografts, the method of organ preservation is the time elapsed between harvesting and transplanting. The number of pre-transplantation blood transfusions, the recipient age, the primary cause for kidney failure. However, HLA compatibility would exert the strongest influence on long-term kidney survival. So take note of this class. Uh, Whenever you would perform transplant in any organ class, hindi lang sa kidney, you have to consider the time elapsed between harvesting and transplanting. That is why class is very important that within hours, actually nga dapat nga minutes lang. Pag hours class, meron silang nilalagay na mga preservative. They would cool, yung rapid cooling, they would cool the organ, preventing na. Dapat talaga minutes lang yun. You have to consider the time elapsed between harvesting and transplant because this time elapsed class can cause organ damage. You have to consider that. Dapat matransfuse ka agad or matransplant yan agad. Then the number of pre-transplantation blood transfusion. Why class? Remember when there are multiple blood transfusions. Kapag meron kang multiple blood transfusion class, you can produce what we call multiple allo antibodies. Magugulat ka na lang class all of a sudden when it comes to the phase of your what they call this, the one wherein you would incubate after adding the LISS. Supposedly dapat there should be no clot after adding. I encountered this in one of my work. We had a patient class. She is a descendant from Germany. Now, the patient already had multiple blood transfusions. Nung case namin, nangyari, I was on duty the next day. Na-report sa akin ng junior ko, sabi niya sa akin, Pete, yung isang patient namin kanina pa nag-incompatible daw sa LISS phase. Pagdating daw sa LISS phase, lagi daw nagkakaroon ng blood clot. So, nag-worry na. Sinek namin yung history ng patient. Yun nga, the patient received multiple blood transfusions already. And it was found out later on that allo antibodies were already produced. Meron na daw siyang iba't ibang antibodies and I believe the patient tested positive for Lewis and hindi ko na maalala yung isa eh. Basta yun nangyari. So, you need to minimize class as much as possible the number of pre-transplantation blood transfusions. Kasi your body could react to the different contents of those blood transfusions. Then you also have to consider the recipient's age. So you also have to consider the health of the organ. If you're going to get a very young, a very old patient or a very old donor class, baka hindi na ganun ka-healthy yung organ. Then you also have to consider the primary cause for kidney failure. If the primary cause for kidney failure, yung we're talking about here class yung recipient. Isipin nyo kung ang primary cause for kidney failure ng recipient is diabetes mellitus. Would you still perform kidney transplant? Ulitin ko yung question class. The recipient has kidney failure. You're going to transplant kidney to the patient. Now, the cause of the kidney failure is diabetes mellitus. So, ito na lang yung itatanong ko sa inyo mamaya instead of the earlier question. Will you still transplant a kidney The patient who has diabetes mellitus and kidney failure. So, yun yung question. Sasalinan mo, matatransplantan mo ba ang isang recipient ng kidney if the patient has diabetes mellitus that causes kidney failure? However, HLA compatibility exerts the strongest influence on long-term kidney survival. Now, ito class, I want you to memorize this kasi tinanong to sa board exam, specifically itong ankylosing spondylitis. So, for HLA antigen class, meron siyang associated diseases. But again, this is not a strong enough diagnostic for prognostic value. So, hindi porket may B27 ka, may ankylosing spondylitis ka. You still need to perform further testing. But again, these are the different HLA antigens and other diseases that they may be statistically associated with. So, pag B27, either ankylosing spondylitis or Reiter syndrome, excuse me. Kapag CW6, psoriasis vulgaris, DR4, rheumatoid arthritis, B5, Behçet's disease, DR3, type 1 diabetes, DR5, gold-induced nephropathy, B47, congenital adrenal hyperplasia, DR5, chronic lymphatic leukemia, and DR5 also pwede sa Kaposi sarcoma. So please memorize this class. This may come out in your quiz and exam. Now, there's what you call allorecognition class. When you say allorecognition, this is the transplantation of cells or tissues between two individuals classified by genetic relatedness of the donor and the recipient. So, ito yung pinaka-best talaga class ng transplant, yung genetic relatedness. Kaya nga ang ideal talaga, if you're going to perform a transplantation or magre-receive ka ng organ transplant, it should come from the someone you are genetically related with. So there are four types. We have your autograft. And when you say autograft, the transfer of tissue from one area of the body to another of the same individual. So an example of this is stem cell blood banking, coronary artery bypass graft. Then we also have your syngeneic graft, the transfer of cells of tissues between identical twins. Then we have your allograft, the transfer of cells or tissue between two individuals of the same species. Solid organ transplant, ang example nito from the liver and cadaveric patients such as liver and kidney. Then we have your xenograft, the transfer of tissue between two individuals of different species. So have you heard of yung pig class na ano na ginamit nila yung pig heart valve? They use the pig heart valve as in a coronary bypass. So kumuha sila ng pig heart valve and they transferred it into a human. So in some religions bawal yun class, but that's one. Now there are two direct mechanisms for allorecognition class. We have your so-called direct allorecognition. In direct allorecognition class, recipient T cells would bind and respond directly to foreign HLA proteins on graft cell. Foreign HLA proteins class may mimic a self-HLA peptide complex due to similarities and structure of the allo HLA protein itself or the structural similarities of allo HLA protein. So sa direct allorecognition class, yung T cell mo a-attack siya or a-attach siya dun sa foreign cell. And when that happens, class, it would cause a reaction that can lead to cell death. So that's your direct allorecognition. They are easily able to identify. Kapag naman indirect allorecognition, secondary pathway by which the immune system recognizes the foreign HLA proteins. It is analogous to the normal mechanism of recognition of foreign antigens, as it would involve the uptake, processing, and presentation of foreign HLA proteins by recipient APCs to recipient T cell. It plays a predominant role in the acute and chronic recognition. So sa indirect class, kasi sa direct, you would have here T cell, tapos diretso ka ng diretso mo nang papatayin yung yung graft cell mo or yung foreign cell mo. Then it would lead to death. Sa indirect class, kaya siya tinawag na indirect is aside from the cytotoxic, walang cytotoxic dito. You will only have the T helper. Si T helper nyo or yung CD4 positive nyo, he would present this foreign particles to an APC. And the APC class would cause the production of cytokines and antibody. Kaya siya tinawag na indirect kasi you do not directly cause the death of the cell death. You do not cause a cell death directly. You need the help of APCs, cytokines, and antibodies. So take note of that. Now, other important component contributing the increase risk of transplant rejection. So, merong mga iba pang components aside from allorecognition. You also have to consider yung ABO blood group antigens. So, this is the one or the only blood group system that impacts clinical transplantation. Anti-A or anti-B antibodies develop in individuals lacking the corresponding blood group antigens. ABO blood group incompatibility, this is a barrier to solid organ transplantation because this antibodies class can bind the corresponding antigens that are expressed on the vascular endothelium. Binding activates the complement cascade, which leads to a hyperacute rejection of the transplanted organ. Recipient donors must always be ABO identical or compatible to avoid this adverse outcome. So please take note of that, class. Then we also have your killer immunoglobulin-like receptors. Ano ba tong killer immunoglobulin-like receptors na to? This is a polymorphic genetic system that would impact allogenic transplantation. KIRs are one of the several types of cell surface molecule that regulate the activity of natural killer lymphocyte. Now, yung NK cell nyo, class, they would technically attach to these receptors. So within the KIRs are activating and inhibitory receptors that would vary in number and type on any individual NK cell. The balance of signals received by the activating and inhibitory receptors would govern the activity of NK cell. Included among the function of NK cells are secretion of cytokines and non-MHC restricted cytotoxicity. Then we also have your immunologic tolerance. So when you say immunologic tolerance, class, please take note that this is the non-reactivity. You would acquire acquisition of non-reactivity towards a particular antigen. When you say non-reactivity, walang pakialam, class, yung katawan mo. Walang pakialam or your immune system does not care about these antigens. Now, there is a so-called self-recognition tolerance. This is a critical process and the failure to recognize self-antigens can result in an autoimmune disease. So, if you cannot recognize self-antigens, class, kaya niyang mag-cause ng autoimmune disease. How? Remember, self-antigens on their own could produce autoimmune or autoantibodies. So if your body isn't able to recognize na, sarili ko pala yan na it's my own antigens, it can cause autoantibodies. So isipin nila na foreign yan and it would cause the creation of autoantibodies. Now, it has been suggested that T and B cells are affected independently and differently and may be tolerated under certain circumstances. During fetal development of the immune system and during the first few weeks of neonatal life, none of the cells of the immune system has reached maturity. For this reason, the entire immune system is particularly susceptible to tolerance induction at this stage of development. So let's go to your T cell tolerance. So sa T cell tolerance, class, it does not show a marked difference in tolerance at different stages of maturation. The antigen required to produce tolerance and circumstances of presentation are specific for each individual T cell subset. So there are three pathways that have been recognized. The first one is your clonal abortion. Immature T cell clones may be aborted in a manner similar to that of B cells. Then we have your functional deletion. The subsets of a mature T cell may be individually deleted, leading to the loss of only one function of the T cell group. And your T cell suppression, which would actively suppress the actions of other T cells, subsets, or B cells. So, sa T cell tolerance class, basically ang T cells nyo would become inactive against antigens. So they wouldn't attack. Wala silang pakialam, class. Kasi nga tinotolerate lang nila. Hinahayaan lang nila. They do not care on how your antigens would enter. So they would let it, and these are caused by three different possible pathways. Yung una, yung tinatawag nilang clonal abortion. In clonal abortion class, yung mga immature T cells, the young T cells class, are aborted in an early manner, similar to that of B cells. So mamaya explain natin yan. Then there's also your functional deletion. Kapag functional deletion naman class, isang set, let's say T helper, they could be deleted, leading to the loss of only one function of the T cell group. So wala kang T helper, ang only active mo lang is yung T cytotoxic. So yan yung functional deletion. One group or one subset is deleted. Then kapag T cell suppression naman, lahat or suppressed ang action of other T cell subsets. So kung wala ng T helper, pati yung T cytotoxic mo wala na din. So those are the possible ways why your T cell would become inactive or would tolerate the presence of antigens. And again, this can cause autoimmune diseases. Then we also have your B cell tolerance. So during B cell maturation, the forms of antigen presentation would produce tolerance would also vary. So mode of tolerance would depend on the maturity of the cell, antigen, and manner of antigen presentation to the immune system. Now there are four pathways of B cell tolerance. We have your clonal abortion. A low concentration of multivalent antigen may cause the immature clone to abort. This is tolerance of immature B cell by this mechanism is high. There's also your clonal exhaustion. Repeated antigen challenge with a T-independent antigen may remove all mature functional B cell clones. Tolerance of mature B cell is moderate. Then we have your functional deletion. The combined absence of the helper T subset and presence of T-dependent antigen or with T suppressor or an excess of T-independent antigen prevents mature B cells from functioning normally. The ability to tolerate B cells by this mechanism is moderate. And the last, excuse me, the last pathway for B cell tolerance is the antibody forming cell blocking. An excess of T-independent antigen interferes with the secretion of antibody by antibody forming cells. B cell tolerance by this mechanism is low. So please memorize this class. So there are different types of transplant rejection. We have two types class, yung hyperacute and your acute rejection. Now kapag hyperacute class, take note that there would be an onset. So the onset for hyperacute from the word hyper is that it would have an onset that is immediate. It happens during intraoperative and post-operative phase within minutes to hours after the vascular supply to the transplant organ is established. Some individuals would possess very low levels of donor specific antibody in the pre-transplant period. In these cases, antibody mediated rejection may take place over several days, and this has been termed as accelerated rejection. So sa hyperacute class, it could occur during the operation itself while you are performing transplantation or hours or minutes after the operation. So this could be very deadly class. So this is mediated by preformed antibody that reacts with donor vascular system. So when you say preformed, it's already present in the body. This may include ABO, HLA, and certain endothelial antigens. Binding of perform antibodies to the alloantigens activates the complement cascade and clotting mechanism and leads to thrombus formation. The result is ischemia and necrosis of the transplanted tissue. Predominant mechanism, hyperacute rejection. This is humoral. The one involved here is humoral. While for accelerated, it would be cell-mediated. Then this is considered as a type 2 hypersensitivity reaction. Then pag acute naman class, this would occur, onset would occur days to weeks after transplant individuals. Characterized by parenchymal and vascular injury. Interstitial cellular infiltrates contain a predominance of CD8 positive T cells as well as CD4 T cells and macrophages. CD8 cells are likely mediate cytotoxic reactions to foreign MHC expressing cells, while CD4 cells likely produce cytokines and induce delayed type hypersensitivity reactions. Antibody may be also involved in acute graft rejection by binding to vessel wall, activating complement, and inducing transmural necrosis and inflammation as opposed to the thrombosis type of hyperacute rejection. Predominant mechanism is cell-mediated, possibly antibody cell-mediated type cytotoxicity. So sa acute rejection class, tandaan nyo lang dito that this is a delayed, somewhat delayed days to weeks. And there would be CD8 positive T cells, CD4, macrophages. And this is a type 4 hypersensitivity reaction. And the last one is the chronic rejection, which would occur months to years. So this would result from a process of graft arteriosclerosis characterized by progressive fibrosis and scarring with narrowing of the vessel lumen due to the proliferation of smooth muscle. Several predisposing factors would impact the development of chronic rejection, such as your prolonged cold ischemia, reperfusion, acute rejection episodes, toxicity from immunosuppressive. The predominant mechanism is that it is cell-mediated. A type of hypersensitivity reaction is 3 and 4. Then another one is your graft versus host disease. So this would occur during the first 100 days post-infusion and targets the skin, gastrointestinal tract, and liver. In mismatched allogenic stem cell transplantation, the targets of GVHD are the mismatched HLA protein. While in matched stem cell transplantation, minor histocompatibility antigens are targeted. The infused T cells can mediate GVHD in several ways, including a massive release of cytokines due to large-scale activation of the donor cells by MHC mismatched proteins and by infiltration and destruction of tissue. Then we also have your chronic graft versus host disease beyond 100 days post-transplant. This resembles autoimmune disease with fibrosis affecting the skin, eyes, mouth, and other mucosal surfaces. Mechanism class is that donor T cells in the graft would proliferate and would attack the recipient tissues, most commonly seen in bone marrow transplant or stem cell transplant. This is a type 4 hypersensitivity reaction. Suppressive agents. So, let's say class, di ba ang normal or the usual acceptable in HLA typing is 6 out of 6. But in some cases, wherein you would get a 3 out of 6, a 2 out of 6. In cases like that, you would need to suppress or you need to weaken your immune system. And to do that, you need to take immunosuppressive agents. An example of immunosuppressive agents class is your corticosteroids. Corticosteroids would inhibit antigen-driven T cell proliferation, inhibit production of lymphokines by preventing monocytes from releasing interleukin 1, thereby blocking interleukin 1 dependent release of interleukin 2 from antigen-activated T cell. High doses of corticosteroids are used to treat acute rejection. Then another one is your cyclosporine A, isolated in 1971 from the fungus Tolipocladium inflatum, has become the mainstay of immunosuppressive therapy in transplantation. Cyclosporine affects T cells preferably by inhibiting the induction of cytotoxic T cells. Cyclosporine blocks calcineurin to the interleukin 2 gene transcription pathway and the release of certain other lymphokines. Then we have your tacrolimus, also known as your FK506. This is a macrolide with mechanisms similar to cyclosporine, derived from a fungus Streptomyces chucoboensis. Its primary target appears to be the Th lymphocytes, or your T helper lymphocytes, with little effect on other aspects of the immune response. FK506 acts early in the process of T cell activation and inhibits the production of interleukin 2. Then we have your excuse me, sirolimus, also known as your rapamycin, previously referred to as rapamycin. Sirolimus is derived from the fungus Streptomyces hygroscipicus from the soil of Easter Island. Inhibits the activation and proliferation of T lymphocyte and subsequent production of interleukin 2, 4, and 15. Sirolimus would also inhibit antibody production. Then we have your mycophenolate mofetil, RS61443, inhibits de novo guanosine synthesis by inhibiting inosine monophosphate dehydrogenase. This drug inhibits T and B lymphocyte proliferation and antibody formation by B lymphocyte. Has been effective as a prophylactic and rescue therapy in refractory renal allograft rejection in clinical trials. Then we have your Nologics, one of the newest drugs, also known as your Belatacept. This drug is approved for use with other immunosuppressants such as your basilizumab, mycophenolate, mofetil, and corticosteroids. This type of drug is called a selective T cell co-stimulation blocker. Then we have your monoclonal antibodies used because the CD3 surface membrane marker is found on all mature post-thymic T cell. Interaction between OKT3 and the surface of mature T lymphocyte causes T cell depletion. The use of OKT3 reverses almost all acute renal transplant rejection. Is indicated for the treatment of steroid-resistant rejection. And there would also be post-organ transplant complications. So it would be viral, such as your cytomegalovirus, Epstein-Barr virus, hepatitis B, or hepatitis C. Cancer, the incidence of non-Hodgkin's lymphoma is increased by 40%. The greatest risk for lymphoma is within the first 6 to 12 months after transplantation. Kaya nga class, balik ako dito. If you're going to undergo organ transplant, you are technically deferred for up to 1 year because of these viruses, tong cytomegalo, Epstein-Barr, Hep B, and Hep C. Deferred ka ng 1 year from blood donation. Then, another possible complication kapag nag-undergo ka ng transplantation, pwede ka magkaroon ng non-Hodgkin's lymphoma by a chance of 40%. The greatest risk for lymphoma is within the first 6 to 12 months after transplantation. Pwede ka rin magkaroon ng osteoporosis class because of pre-transplantation immobility. Di ba pag nasalinan ka ng organ, di ka naman kagad nakakagalaw, and that could cause osteoporosis as well as the long-term effects of steroid therapy. You could also develop diabetes class. So this is due to steroid-induced hyperglycemia. Then there would also be hypertension class due to it could possibly be due to a pre-existing medical condition or associated also with renal failure and can negatively affect the patient's general health and graft survival. Pwede rin magkaroon ng hypercholesterolemia. Increased blood cholesterol is a serious post-transplantation concern because of long-term vascular effects to the patient and engrafted organ. Can result from the return of the patient's appetite and the lifting of dietary restrictions. Then we also have laboratory evaluation of potential transplant recipients and donors. So you need to perform HLA typing class. So this is the phenotypic or genotypic definition of HLA antigens in a transplant candidate or donor. So for clinical HLA testing, phenotypes or genotypes of the classical transplant antigens or genes are determined. So you're going to identify class yung HLA, B, C, DR, and DQ. So we're talking about class 1 and class 2. So you need to determine this phenotypically and genotypically. This information is used to find the most suitable donor recipient. It must be stressed out that other considerations go into the choice of a particular donor for any given patient, be it a solid organ or a stem cell transplant. Now, there's the so-called phenotypic. So, dun muna tayo sa phenotypic. Di ba sabi ko kanina, you need to determine this phenotypically or genotypically. So, the first one is the phenotyping. And this is based class on the so-called complement-dependent cytotoxicity. So, you're going to use here purified T cells for class 1 typing. So, for A, B, and C, ang reagent mo is purified T cell, ang sample mo. While for type 2 typing naman, purified B cells ang gamit. After incubation with the antisera, which is your reagent, so you add your antisera, after adding your sample na purified T cell, B cell, complement is added. So complement is activated and cells are killed. A vital dye is then added. When you say vital dye class, these are used to stain. Nag-i-stain yan ng mga live cells, mga buhay na cells. It would help in distinguishing between live cells from dead when they are viewed microscopically. Using this assay, an extensive array of HLA antigens can be defined. So kapag mas madaming live cells. So how would you know na madaming live cells class? The stain is absorbed by the cell or na-uptake niya. So kapag na-absorb yung stain, marami ka nakita ang kulay blue, then CDC is ineffective, meaning compatible. So the usual vital dye use is trypan. Pero kapag marami ka nakitang no stain class, meaning there are a lot of dead cells. Kapag maraming dead cells, incompatible ka. So I hope that was clear. Limitations class, viable lymphocytes must be used which demands timely performance of the assay. Separation of T and B lymphocyte is required for definition of class 1 versus class 2 antigen. The source of antisera for HLA typing is not always consistent or reliable. Thus, the agents can vary in quality or quantity over time. The level of resolution, the ability to distinguish two closely related yet distinct HLA antigens is limited. So, meron kasing mga antigens class na HLA 9, HLA A9, A1, mamaya masyado silang related. So, hindi mo siya ma-differentiate. So, to do that, you need to perform genotyping. So, the most common approach for analysis would include PCR. So, kapag genotyping, we're referring to molecular methods such as your PCR. So, you're going to perform PCR amplification of HLA genes with panels of primer pairs, each of which would amplify specific alleles or related allele group. Amplification is detected by agarose gel electrophoresis, and only those primer pairs that bind to the target gene would result in the detection of an amplification product. The HLA type is then identified by determining which primers resulted in amplification. A second common approach for HLA genotyping is to perform a single PCR reaction that will amplify all HLA gene variants at a specific locus. The amplified gene is then subjected to hybridization with a panel of DNA probes, each specific for a unique HLA allele or allele. Only those probes that can specifically hybridize to the amplified DNA will be detected. A third common method for HLA genotyping is sequencing of PCR amplified HLA genes. Advantages class it basically overcomes the limitation of the phenotyping. Cells do not need to be viable in order to obtain DNA for HLA genotyping. Typing reagents are chemically synthesized, thus there is no reliance on human donors of antisera. HLA genotyping can provide varying levels of resolution that can be tailored to the specific clinical needs. So that ends your module 9. Thank you.